So after all the talk since morning on sleep and diet and telomeres, everything, so now we come to the psychosocial impact of menopause on women. So menopause is one of the age-related phases of physiological transition of females. Menopause is encompassing the perimenopause, postmenopause in a transformative phase marked by hormonal shifts that can precipitate or exacerbate the psychological, mental, and social health challenges. There is robust research and information regarding its biological aspects, especially in endocrine base, yet the psychosocial aspect is quite interesting and debatable due to its variability among different cultures and climates. There are certain sub-threshold response in form of fear and loss of reproductive life to no more liability to reproduce and a feeling of loss of femininity. Psychological factors such as personal or interpsyche personality, self-esteem and coping skills, and intra-psyche, relationship issues and social support may contribute to the onset, cause and response in the phase of transition. So the key psychological and mental health issues are mood disorders, where we see depression and anxiety are common, with some women expressing a window of vulnerability bit more to these symptoms than the other women. Cognitive changes known as the brain fog. Women often report reduced attention, memory problems, and difficulties in finding words. Emotional liability, increased irritability, panic attacks, feeling of reduced confidence are often reported. Sleep disturbances like insomnia caused by night sweats and anxiety often exacerbate low mood and poor cognitive performance. Body image and self-esteem, physical changes like weight gain, and skin changes along with psychological impact can lower the self-esteem of the woman. These are some of the common menopausal symptoms which lead to this psychosocial impact on the woman. Hot flushes, low libido, night sweats, frequency of periods, insomnia, brain fog, weight gain, low energy levels, and mood changes. The typical symptoms of depression include the depressed mood, anhedonia, and fatigue. Reaching a diagnosis of depressive disorders, two internationally recognized criteria are ICD-10, International Classification of Diseases, and DSM-5, this is a Diagnostic and Statistical Manual of Mental Disorders. Symptoms should be there for at least 2 weeks, and any poor social or occupational functioning and condition should not be due to any substance use. Presence of at least 2 typical expressions with 2 common symptoms constitute the criteria of major depressive disorder, or which is F32 according to ICD-10, while presence of at least 1 typical and 5 or more common symptoms constitute to the criteria to diagnose DSM. Apart from anxiety and depressive disorders, the other psychiatric conditions that have been linked to menopause are premenstrual dysphoric syndrome and a rare condition, trichotillomania, described, which will be discussed as under. Premenstrual dysphoric syndrome includes a condition of changing moods with changes in hormone levels every month before periods. Anecdotally, many cases as they approach to menopause report that their symptoms of premenstrual dysphoric syndrome worsens at onset of perimenopause and alleviate with menopause. Trichotillomania is a hair pulling disorder with symptoms worsen at perimenopause. The contributing psychological factors are life transition. Menopause often coincides with midlife stress, such as caring for aging parents, empty nest syndrome, career pressures, lack of social support, unemployment, surgical menopause, poor overall health, and past history. Women with a history of depression or poor adaptation to stress are at a higher risk. The female reproductive hormones and rapid changes in their levels may influence neurotransmitters in the brain, particularly the serotonin and gamma-aminobutyric acid systems. Estrogen modulates the serotonin to increase serotonin presynaptic uptake, which in turn modulates the norepinephrine levels, which decreases the monoamine oxidase levels and affects the dopamine turnover. If this increases the brain excitability and affects endorphin levels and possibly interacts with gamma-aminobutyric acid. Progesterone is found to increase the monoamine oxidase levels. In high doses, progesterone has an anesthetic effect and may decrease brain excitability through an interaction with the gamma-aminobutyric system. The drop in estrogen levels during perimenopause and menopause can lead to hot flashes that disturb sleep, to anxiety, fears, and mood swings. The key social issues are workplace stigma and productivity. Many women felt compelled to hide symptoms at work due to lack of supportive policies and fear of being stereotyped as less competent or irrational. The common issues, which include reduced confidence due to brain fog and memory loss, can undermine the occupational self-efficacy. Inadequate environment, high stress of poorly ventilated workplace can exacerbate physical symptoms like hot flushes. Then the economic impact, women may turn down promotions, reduce the working hours, or leave work early due to the unmanageable symptoms of menopause. Then the relationship and family issues also has a great impact. It can significantly alter family dynamics and intimate relationships. The communication gap, the husband or partner may lack knowledge about menopause, leading to misunderstandings, reduced intimacy, and increased marital conflict. The sexual health taboo is also there. Vaginal dryness and low libido are often difficult to discuss, leading to sexual avoidance and feeling of isolation. The Western culture often reviews this stage as a loss of youth, fertility, and attractiveness, and usually these women tend to be socially invisible because cultural emphasis on youth can make menopausal women feel invisible or purposeless. Then factors such as education and income level directly impact as to how menopause is experienced, and rural women often face greater stigma and limited access to specialist care as compared to the urban counterparts. So there are some semi-modifiable culture policy environments, some semi-modifiable living and working conditions, some semi-modifiable social community factors, and modifiable life factors such as smoking, diet, alcohol, and exercises. Non-modifiable may be race, ethnicity, and sexuality. Then there should be some support strategies to help these women to overcome their psychosocial problems. So strong social support networks are vital for reducing these symptoms' severity and improving the quality of life. Education program teaching partners and family members about menopausal changes can improve emotional support at home. So always when a patient comes to you at the menopausal clinics, the husband or the family member should accompany them so that they can also be guided that these problems are genuine actually, and they should help the women to overcome these problems with their support. And at the workplace, organizations are increasingly encouraged to adopt menopausal informed policies such as flexible working hours and temperature controls. Cognitive behavior therapy is highly effective in mood swings, depression, and anxiety as recommended by the NICE guidelines. Then lifestyle modifications like addressing sleep and physical health by encouraging regular aerobic exercises as a low cost and high input mood stabilizers are also helpful. Eating healthy food with lots of fruits and vegetables and limiting overly processed foods, excess salt and sugar and wide refined carbohydrates can be beneficial. Foods high in essential fats such as omega-3 oils and those rich in B vitamins are calcium, and vitamin D can also help improving your mood. Then practices such as mindfulness-based stress reduction, yoga, meditation help to lower the cortisol levels, hence they reduce the anxiety and improve the social stability. Holistic approach is required in containing the psychosocial issues. Lifestyle changes and stress reduction to address the mood swings and depression is very much helpful. Medical treatment in the form of menopause hormone therapy can go a long way in improving the quality of life in menopausal women. For women with clinical depression or anxiety, SNRI or SSRI can also be helpful. Then pharmacological interventions are definitely helpful. Hormone replacement therapy used for vasomotor and psychological symptoms may improve mood in perimenopausal women. It is not a primary treatment for major depressive disorders. Then estrogen therapy will help in mood improvement, effective in perimenopausal women, especially helpful with hot flashes and sleep disturbance, and its mechanism is through serotonic modulation. Then progesterone therapy is added for endometrial production, micronized progesterone, and is better tolerated. Mood effects vary depending on the formulations. Androgen therapy is not routinely used for mood disorders, limited evidence for mood benefit, role mainly in hypoactive sexual desire disorders. The antidepressants may also be helpful in these conditions. SSRI antidepressants including citalopram, fluoxetine, paroxetine, sertraline, and non-SSRI antidepressants including venlafaxine and venlafaxine may be helpful. Then the role of the menopausal specialist is due to increased life expectancy. Stage of menopause accounts for almost 1/3 of a woman's life. So encourage multidisciplinary approach for early screening of any NCDs and to promote awareness regarding care of the mental health. Help the woman with lifestyle modifications, individualize the hormone therapy, counseling of the family and of the patient as and when required, and develop specialized state-of-art menopausal clinics. Thank you.